Okay. Well, welcome back, everybody. We're very grateful that you're joining us for a continuation of our Bold and Brave Conversation series. And just a quick summary, that this series is an opportunity to participate in multiple varied conversations and discussions that are focused on having hard, honest conversations about breast cancer. They're hard conversations, but they're ones that very much matter. And that's why we're here doing what we're doing. And it's an opportunity to gather in a space that's free of judgment and to view each other in a holistic manner, head to toe as whole people. And ultimately the goal, like all of PINK's programming, is really to empower survivors. And so we hope that that we can achieve that goal tonight. And certainly you can access our prior sessions on the PINK's YouTube channel. I think those are posted and ready to be viewed. So with that, I think we'll get underway. And tonight we're going to talk about planning for disease progression. And that's a wide net to cast, and we're going to do our best to try to capture most of the important details. Obviously, as Jamie talked about, the chat is open to send in questions, and we'll address those as we can. I think we'll start with maybe just a real quick review of session one, because there was a few submitted questions that really were, Dr. Geetha, probably geared towards you, but really asking about some specifics about prognosis and diagnosis. Most importantly, maybe if you could briefly touch on stages of breast cancer, and there was a question addressing the prognosis of mutations.
Okay, good evening, everybody, and thank you for joining us. And breast cancer is a very common cancer, and 1 in 8 women will get breast cancer in their lifetime. Breast cancer can be divided into 4 stages of cancer. Stage 1 and stage 2 are considered somewhat early stage. Stage 3 is locally advanced, and stage 4 is metastatic breast cancer and is not curable cancer. Now, stage 1 is a smaller tumor that is confined only to the breast. Stage 2 is a slightly larger size tumor, still confined to the breast, and sometimes it can be spread to the lymph nodes. One of the questions we had was whether the cancer has metastasized to the lymph nodes. It depends on the location of the lymph node. If the lymph node is only in the armpit and the cancer has spread only to the lymph node in the armpit, it is still considered as locally advanced cancer, but it is not metastatic. However, even though we call it as metastatic to the lymph node, but the lymph node is in the axilla, it can still be cured. However, if the cancer has spread outside to other lymph nodes in the abdomen or to liver or lungs or bones or brain, it is called a stage 4 cancer, and that is not curable. I hope I answered that for you guys. And if it is still not clear, please let me know.
Cynthia, from your perspective, are there any questions related to that you would have liked to have known?
Yeah.
I would say, I think there is, if you can clarify, Dr. Geetha, because we get a lot of questions about this, is particularly if you weren't metastatic, you had breast cancer, you were cured, went through treatment, and then had another breast cancer. A lot of people think, oh my gosh, I've had a recurrence. So what is the difference between a recurrence? Is it a new cancer, or is it metastatic if it comes back in the breast? I think that's so confusing, and people get really scared. And so the question is, well, am I metastatic or not? Because they've got a different cancer. Or maybe that's a very good question. And it's one of the ways to kind of trying to figure that out is if the cancer comes back in the breast, we call it as locally recurrent breast cancer. And whereas it's metastatic means it's left that organ where it started from. It's no longer in the breast when it is metastatic. Whether it is metastatic to the lymph nodes in the armpit, that's where it will be regional metastatic cancer, where it has gone to the axillary lymph node. But once it has gone to other parts of the body, it is metastatic and it's not curable.
The locally recurrent is a higher risk because we always worry about some cancer cells sitting somewhere else that we don't see. And that is why we are so hesitant to use the word cure, because we are always, even in stage 1, stage 2 cancers, some of the doctors will always say your cancer is in remission, which means we don't see any cancer cell that we could see at this point. We don't see any evidence of cancer that we could see. But that does not mean there is few cells that we, that's why we always give hormone blocker for 5 years, longer, 7 years, because we are always treating what we don't see. And that's why there is a prolonged treatment, if that makes sense. So I'm very hesitant to use the word cure, definitely not in metastatic cancer stage 4, but in locally advanced. We try to quote unquote call cure, where we try to treat them more aggressively, and we use still sometimes aggressive options so that they can have a prolonged survival. But the word cure means it should never come back. And that even in stage 1, sometimes it has come back. So, that word is very fluid, but it's very important for patients. For the patients, they need to hear the word, I'm cured. Yeah. And, which, especially in breast cancers, we always find it harder because we say that you are in remission, which means we don't see the cancer at this point. And patients always ask me, am I cancer free? And that is another word that commonly people ask me. And I always say, at this point, I don't see any evidence of cancer. Now, I hope you live up to 90 years or whatever age, and you don't see any evidence of cancer. That's my hope. But I only take it one day at a time, or one. And that does not mean they have to live in fear. A lot of those things are same in medicine. We only cure few things 100%, like pneumonia or a little infection, other things that does not come back. But otherwise, a lot of the things we manage, like diabetes, we don't cure. High blood pressure, we don't cure. We treat them with medication so that they can live to the fullest. And same with metastatic breast cancer. We are hoping we can mimic that way. Maybe not that long lifespan, we are not getting there, but that is the eventual goal for us that we can manage.
Perfect. Thank you for answering that.
Is that helpful, Cynthia?
It does. Thank you.
I would, maybe you could speak a little bit to, and I don't want to get too far into this because this is really, a lot of this is in our first one, but is it fair to say that with the advances that cancer treatment has seen, that cancer is becoming or has become or is moving towards a chronic disease?
Absolutely. And that is where we are seeing more and more patients living longer and longer. The question at that point we are trying to see is, they are living longer, but can we make them also live better?
Right.
Longer. And that is the trade-off that we are trying to see, that some of our patients have least toxic treatments and are living very, very long, but some of them are living longer, but their quality of life has gone down with what we do. And that's a fine balance. Certainly treating metastatic breast cancer patients is a lot of science, but definitely there is some art and some, how do I put this, like a healing process in this. It's not straightforward like a pure science, where you combine a lot of input from the patients, you listen to the patient's cues and move forward with the treatment options. But it has definitely become a chronic disease. Of all the cancers, I think metastatic breast cancer is the one where, especially the hormone positive breast cancer, has become way more chronic disease than what we think with certain to other cancers.
And you bring up quality of life, and that's an excellent transition really into more of the meat of tonight's discussion. There's one more question I don't want to overlook that somebody's asking about. Maybe can you speak very briefly to the subcategories of each stage, right? 3A, 3B, 3C.
Yeah, so it depends on, so there is two types of staging that we use. One is an anatomic staging and the other one is prognostic staging. And so the anatomic staging is purely based on the size and how many lymph nodes are affected. And we always use T1, T2, T3, and T4 stages. T1 is less than 2 centimeters. T2 is between 2 to 5 centimeters. T3 is more than 5 centimeters. And T4 is where the cancer has gone to the chest wall. We call it as T4. And then we have N1, which is lymph node N1, where it is 1 to 3 nodes affected. N2 is 4 nodes, 4 to 9, and then N3 is more than, or internal mammary, a node inside the chest is affected. And then M is where the cancer has spread to other parts of the body, where it is anything liver, lungs, bone, or brain, or anything, even the other side of the lymph nodes in the other axis, the armpit of the other side of the breast cancer. That will all be considered as M1. M1 is metastatic breast cancer. We traditionally call that a stage 4 breast cancer, and that is not curable. And there is also a prognostic staging, and that's where the patients sometimes can be confused. My one doctor said one stage and another doctor said another stage. The prognostic staging is, we realize that some patients can have a larger size of tumor, but biologically the cancer might be less aggressive, and a smaller tumor might be biologically more aggressive. So there are 3 categories in that. One is what we call as a luminal A, hormone positive breast cancer, estrogen strongly positive, progesterone strongly positive. HER2 is a protein, 1 in 4, 1 in 5 breast cancer patients have that, and that will be negative. So estrogen positive, progesterone positive, HER2 negative, that is a so-called good risk breast cancer. And then we have what we call as the luminal B patients, where they are estrogen positive, they might be progesterone negative, and HER2 will be negative. And they're somewhat biologically aggressive breast cancer. Even though it is hormone positive, they are biologically aggressive cancer. And I always call that as like a wolf in a sheep's clothing. It looks like hormone positive and it looks favorable, but they do have certain high risk features. And then we have triple negative breast cancer, where estrogen is negative, progesterone is negative, and HER2 is negative, and 20% of breast cancers are like that, and they are one of the most aggressive breast cancers. And then we have HER2 positive breast cancer, which can be either hormone positive or hormone negative. If it is hormone positive, we call that as triple positive breast cancers. And if it is hormone negative, it is HER2 positive breast cancers. And these are all determined by the biopsy. The pathologist will give us that diagnosis. And based on that, sometimes we do a prognostic staging where even if it's a larger size, we try to plug in all those numbers and say, okay, this is your anatomic stage is 3, but your prognostic is 1. And so your doctor should individually, you should talk to your doctor and know those stages. One based on the size and location of lymph nodes and number of lymph nodes, that is anatomic staging. The prognostic is not only based on the size, but it also includes the estrogen and the progesterone and HER2 and the grade of the tumor, how fast and biologically how aggressive. And that gives you somewhat a prognostic staging. So prognostic staging has got more value than anatomic staging, of course. But a doctor might combine back and forth. And so sometimes patients can get confused. So it's important for you to discuss with your oncologist to know what's your anatomic staging and the prognostic staging.
Yeah, and I would say a lot of that is really important for those inside the medical chart to communicate with each other, right? I mean, and that's a lot of what that is. And
Yeah.
That's a great explanation. There's a lot more to that conversation, I know. But I think I would leave that with, I think we would all encourage everybody to ask that question when you're in the clinic, right? Because you need that information. Lots of the discussions we're going to have tonight and in the months down the road are much more effective conversations and discussions when you personally have that information to be able to make decisions for yourself. And so I think we'll leave that there. There's great additional information in session 1. And again, I would encourage everybody to go watch that if you have not already. So I think with that, we'll launch into kind of the first big umbrella topic that we had tonight. And really that's what to expect physically and mentally with disease progression, and specifically with disease progression towards the end of life. And I might add in there, in addition to physically and mentally, emotionally and spiritually, because there's lots to kind of unpack with all of that stuff. So I think we're in a unique opportunity tonight. We have a survivor, we have a palliative care physician, and we have an oncology physician all in the same room, virtually albeit, but all at the same table. That's not very common. And so we have an opportunity to kind of share each other's viewpoints they're all right as well as they all may be wrong, right? It's all a perspective, but we can speak from the experiences that we have and what we typically see. And I think that's a pretty unique thing that we're going to launch into tonight. So I think I'll start kind of with my take on that, and then maybe Dr. Geetha, you can add your thoughts, and then maybe we'll circle back towards Cynthia to fill in some of the emotional, spiritual, mental aspects of that. So I would like to say that this question is great, and it really gets in my mind to what I see. I talk to lots and lots of people about death and the end of life and what ifs, and when you start to really you peel that discussion, there's a lot of fear there. And what I have found is that most people, when you really can dig into that conversation, the fear is not about death, but the fear really lies in the process of getting to death, right? The process of dying. And that's the part that most people really start to ask a lot of questions. And so hopefully we can talk a little bit about that tonight, not to make it more scary, but to make it less scary. And I think if there are some knowns and some ideas of what to expect, it makes it an easier process, if that's fair to say. So I would say that death, like birth, is an active process, and sometimes it's hard, but oftentimes it's not. And I have found that the hardest deaths are amongst the people and families in which these conversations and death and the end of life are taboo topics, in which they're shut down, they're not discussed. Those end of life experiences, in my experience, have been significantly harder than families and people who have had open, honest, real discussions long before that event occurs. So to that, I think, to speak some of the physical things that we see as breast cancer progresses is that they all relate to the body slowing down. And we don't have labs and x-rays and studies to show us that slowing down, right? I mean, we can do labs and we can poke people with needles and take pictures and look and say, this all looks great, but we see that the body is slowing down. And what that often looks like is increasing weakness, increasing fatigue. We see people eating less. We see people sleeping more. We see a social withdrawal, purposeful social withdrawal. We sometimes see cognitive changes, maybe some confusion or some disorientation. And then we certainly sometimes see symptoms, right? Pain, nausea, dyspnea, constipation, anxiety. But the bulk of those are very manageable, and we've learned to do that really well. So we can take that piece out of the picture as far as things to worry about. When in that there's a next question is we're going to talk about the timeline, but the things that I just talked about, sometimes those happen over a matter of weeks, and sometimes those happen over a matter of many months. That process looks different for everybody, but to be aware of things to observe and be able to piece that into the bigger picture, I think is very important. If we're going to talk about, Cynthia or Dr. Geetha, please pop in here if you want to add something. But I think when we talk more about the imminent end of life, and that's much more where we say that's an active process. Those types of things that we see physically is somnolence and lethargy and sleeping quite a bit more. We eventually will see a lack of eating, a lack of interest in eating. We'll see fluctuations in vital signs. That's blood pressure, that's heart rate, that's temperature. Those are changes in the respiration patterns. Sometimes we see agitation and we see delirium. One of the more fascinating things that I observe is that we see people talking to and about people that have passed before them, not in a scary way, not in a surprising way, but a very matter-of-fact conversation. People will mention this person or that person, or they see somebody. Lots of times it's their parents. And we hear people, if you listen to what people say, it seems very out of context sometimes. And we say, oh, somebody's confused or disoriented or they're delirious. But my take on that is a little bit different. I think sometimes if you listen to what people are really saying, they're explaining what their process is, what they're going through, right? People say, I need to get in line. I don't want to be late. I hear all the time that people want to go home. And so, I kind of presented those in two different subsets. And one, that first set of things that we see physically, that may happen over many, many months. The second set, the more imminent end of life, those are things that we typically see occur in the last days or weeks of life. I don't know, Dr. Geetha, that's from my hospice and palliative approach. Again, the time that I'm meeting those people is oftentimes at that time of life. So, I think getting your perspective way upstream from that, the things that you're observing would be really beneficial as well.
So, when I see a patient with metastatic breast cancer at the time of diagnosis of metastatic breast cancer, I always try to assess where the disease burden, how much tumor volume they have, that kind of to some extent, and then to look at the biologic type of breast cancer, like we talked about triple negative or HER2 positive or hormone positive, the location of the cancer, how active they are physically, what kind of emotional status they are they working full time? Is that person a runner and they're very active physically? They have where the location of the cancer, where they are in their life. And sometimes patients at the diagnosis itself, they are very willing to go through an honest conversation of what is my time frame, where is my disease, what kind of treatment options do I have? Sometimes they're overwhelmed just with the diagnosis and they're not ready to hear that conversation, or they don't want all the conversations at one go. And so I have to break it into pieces in that situation. And there are some patients who are static because we always try to start with the least toxic treatment, because once we know that it's no longer curable, at that point, my goal is, can I get a lot of mileage out of the least toxic treatment so that they can be as functional as they can, and they can spend more time in their house with their family rather than in my office or in the chemo chair. So we will try our best to keep them on a hormone blocker or an oral medication as best as we can and as long as we can, so that the benefits at that time are way more than the risk of the medication. But at some point that equation can change. Now that can change within 2 months, or they can change after 5 years or 10 years. It depends on where their cancer is progressing and is it still responsive to hormones, or do they change to a more aggressive treatment, or is it in a location where I need an immediate control of the cancer. So those are all the things that will make us decide whether are we going to change from a least toxic treatment to a slightly more aggressive treatment. And that will be very tailored towards that particular patient. And it's very different for different patients. So sometimes when patients try to cross compare with each other's regimen or treatment, it completely varies. We do not know the biology of the cancer. We do not know the location of the cancer. We do not know the tumor burden, how much disease they have. Do they have only one spot with 5 millimeter in the liver? Or do they have a 10 centimeter spot in the liver? Those are all will help us determine. And one of the biggest factors in determining the treatment is the patient's performance status. Is the patient driving to my clinic, walking independently, going up and down the flight of stairs, or is the patient coming to my clinic with 2 people or in the wheelchair, how sick they are? That will tell me how much they can tolerate the treatment to some extent. And so as the treatment prolongs, some of them are very static. They don't change the treatment for 5 years, 10 years. And I've been blessed with some of the patients who are very, very stable. And some patients, after 3-4 years, we have to slowly change one treatment to other treatment, and gradually they are getting weaker. And so then we kind of start having those conversations about what the further treatments will look like, how much they want aggressive treatment, what kind of side effects those treatments can have, how much they can get in for what they give in. So everything in life is, you always have to have some, it doesn't work always, everything is good and, no side effects. All our treatments have some side effects, and you're always looking at pros and cons. And at the end of, if they're not able to do more treatments, or their cancer is getting worse and they're struggling, we always try to clarify the goals of care at each visit, or at least every other visit we try to re-clarify, because initially a patient might be in one phase of their life and that things might change over a period of time. So it's important to constantly clarify with the patient that that our goals are, are aligned with their goals. And that is important. And because at the outset, the patient might say, I want very aggressive treatment, this is where I stand. But we all change our minds as human beings, and someone who's going through such a toughest time in their life, they're allowed to change their mind back and forth. And it is a hard process. We all get to make these tough tough decisions once in our life, and that's the toughest decision a person has to make. And so being patient with them, giving them all the information, and letting them ask as many questions as they want to ask us, so that they are comfortable with the decision making. That's how I approach. Is that what you wanted to hear? I was not sure.
I mean, really, what we all want to do is just we want to give people as much insight and knowledge, I think, about this process, because ultimately, like you said, we all get to make our own decisions. But the more information and education and knowledge we have, the better we can do that. And you talked about matching goals, right? And that's really, really important. And that matches quality of life, and that's really, really important. And that's defined differently by every person who goes through this, right? I've had patients who say, if I can open my eyes and see my grandkids, I'm good with that. And I have other patients who say, if I can't go to the bathroom on my own, if I can't put my own pants on, that's not a meaningful existence for me. And I don't want to go through burdensome things to achieve a quality of life I don't appreciate. So there is no right or wrong in that. And I think that's the hard part of this discussion, is that, everybody's got to take that information internally and figure out what's right for them. And so there's a couple of great questions that are popping up. I'm going to come right back to those, because I want to get Cynthia's take on kind of the mental, emotional, spiritual expectations, or things that, one might be able to kind of think about or plan for.
Specific to disease progression, right, Clay? Is that what we're kind of trying to focus on? So, I've been at this now, March will be 6 years of progression, and it has progressed for 6 years, and each progression is something that we have to, and I think I said it the last time, we have to evaluate every time there's a decision to be made and a conversation to be made with my medical team. And I think going on the, expectations, what do you expect? I think that it's like a box of chocolates. Literally, I say it all the time. You don't know what to expect, because one day it may be X and the next day it's Y. You may wake up and have not had any problem with one thing, and then something pops up and you're like, where did that come from? And so, and I think I talked about this, it's like, well, I'm going to let it set for 2 or 3 weeks or a month, and then I'll address it if it's still there, because we forget, and let me speak for myself. I forget that I am a cancer patient, but I'm also a normal 50-plus-year-old woman that is going to have all the normal 50-plus-year-old woman problems. And so it's not always cancer. And so we have to remember, I think getting the cancer card's enough, but evidently life doesn't work that way. So I think it's a matter of, that to me is hard. I get, it's like, that's just a bad draw. But I think not having expectations, I guess, is one of the things that I'm open to finally it took me a while, and it's like, I'm going to make peace with the fact that I have metastatic disease and I cannot control it. We mentor this in our retreat program. There's just some things you cannot control, but it doesn't mean I can't make peace and partner with it, right? And be smart about it and work with my family, my caregiving team and my medical team to live the best life I can. And that changes literally sometimes on a daily basis. And I have to be okay with that. What choice? It's a choice. And we also teach that as well, but I can choose to be mad about it, or I can choose to say, how do I live with this? Because every moment that I fight, and I don't use the word fight in the sense of I'm a fighter, but every time I fight with the disease emotionally or physically, I lose. I'm just going to say it. I lose every time because I can't take it away. I can't not have metastatic disease. And if I stay there very long, that's when the depression will kick in, or the frustration or the anger, all of those grieving emotions. So I had to lean on my spiritual and emotional well-being to say, how do I get there? And there's a song by Ann Wilson, and it's just like, let me tell you about my Jesus, my spirituality and my connection with my God, my Jesus. I hit the ground, but my knees hit the floor and my arms raise, and so do my eyes. That's how I cope. And that's really important. It may not be, I understand everybody's got different beliefs, but for me, I hone into what is at my core heart and soul that brings me peace and comfort. And I have to lean on that, because if I didn't, I wouldn't be able to get out of bed some days. And so it's finding what brings you peace. And I think a second thing with that I'll add is having the trust in your medical team to know that they understand where you're coming from and what your wishes are and how you want to be advocated for and treated with that mindset, and that they're all on the same page is part of that comfort I get. Because if they don't get it, I need to make sure they get it. And if they won't get it and will not react in a way that is comforting to me, then I need to find another doctor that's going to support my way of quality of life that's important to me, that the decisions I've made. So having that medical team all in line and in sync, doing that dance with me and caring, if they're approaching it the same way I feel like I need cared for, that is a huge comfort emotionally and physically as a metastatic cancer survivor. I can't stress that enough. And I'm so blessed that it took a while, but it works. So that's important. And from an emotional perspective, when we talked a little bit about this last time, having those people in your circle that can love you and lift you up, that you can trust your heart with, is priceless. So that would be my answer to the physical part, the emotional, and the spiritual. I hope that answered it. I don't know if that helped or not, but that's how I would approach it.
I thought it was great. And I maybe would just add two points of clarification. And maybe it doesn't need clarification. I know where you come from, but you talked a little bit about coming to peace with where we're at, where you're at in that process. But I would caution people that that's not an avoidance, or more importantly, a denial, because avoidance and denial really oftentimes creates a much harder process. And more importantly, I think oftentimes ends us in a position where we didn't get to achieve what our goals are, and we didn't get to live a quality of life that we found valuable. And so I think that it's not a judgment by any means, but I would just caution people from trying to tease that apart, right? Like packing it away and just avoiding it isn't really what you're talking about.
No, I think it's facing it actually. And just, it's like, do I have a death wish? Absolutely not. But can I stare it in the face and say, I can't change it? And in all likelihood, I will die of this disease, but I could be hit by a truck tomorrow. We all hear that saying a lot, but I'm at peace because of my relationship with a higher power, which is God, right? So I was speaking with someone the other day, and we got some news where I've got now some kidney issues, right? And it's like, is it cancer or is it just normal? There's some, anyway, we can get into that a little bit later, but it's, for the first time you start, it's like, oh, is this the end or whatever? And you're like, okay, God, if this is it, this is it. Let's do this when you're ready, not my call. But you realize that when you don't have control, you face it and you just say, I'm not giving up. I'm not fighting the fight. I get up every day, just the opposite. But I just, in all likelihood or not, I win every day I get up, right? For me, if I'm functional. Now, I will be one of those that when I'm not, it won't be a winning day for me, but because I have high expectations. But I think it's not running away or avoiding, it's facing it, and we're grieving. I think the person there, we talk a lot about grief, and I think your family and loved ones anticipate you being gone. So that's a different grieving process. But for me, I grieve my leaving this earth with my loved ones before I leave, because once I leave, hey, it's going to be great, right? Like, and I told someone the other day, I've been mentoring the I get to for a long time now, replacing that with, oh, I have to do this or I have to do that. Well, I like reframing and saying I get to do this, right? Because I'm alive and well enough to do it. Well, I get to go and meet my maker. That to me is so incredibly amazing. Am I in a hurry to do it? No. But does that bring me peace? Yes. So, that's just kind of where I'm at, and it brings me personally comfort, and I hope my family and friends.
Yeah, that's really well said. I thank you for that. That's meaningful. And the other piece I just wanted to add to the conversation about your caregiving team, your medical team, is the reality is you're hiring these people. You're hiring these people to care for you. And if you don't jive with somebody, you got to go find somebody that you do, because I think we all need peace of mind. We need peace of mind going through this process, that the information we're receiving, we can trust, the decisions that we're making, we can trust. And I think if you have somebody on your team that isn't that person for you, I think, again, I'm not encouraging people to doctor shop, because there's some hazard in that as well. Mm-hmm. But I think it's an important thing to consider. I mean, if that is a person on your team that is charged with providing you disease-focused treatment, you have to have a level of comfort with that person. And the bottom line is you're hiring these people to care for you. And
think of the care, and I look at this way, think of the care that we take in going and choosing a hairstylist, literally to style our hair or do our, a facial or whatever. It's important, and that's important to you. Well, why wouldn't that be 100-fold when you're going to be in the fight of your life long-term with your care provider? And maybe you've changed, or your goals have changed, and that provider, that doctor is really struggling with that. That's no harm, no foul. It's just not a match anymore. And it's okay to say, I don't think that this is a relationship that works anymore. If you don't find comfort with a person on your team, I'd do something about that, because I will tell you, there is a lot of peace of mind that comes with that. It really is. It's like, at the end of the day, when I'm questioning stuff, I go back to the question of, do I trust my care team and my circle, my medical team? And I trust them. And that is so important. Then I can let it go, because I'm not a doctor. I'm an advocate, but I'm not a doctor. So, but it's important that all of them are in line with me.
there's some excellent questions coming in here too, and two, there's a few that fit in what we're talking about, the physicality of the process of dying. So there's one, I don't know, can I scroll that chat box down? Oh, there we go. Okay. So it says death in palliative care. When people leave their physical body, are they in pain and does it hurt? I mean, I would have to say we're never going to know until we get there. I can tell you outwardly what they exhibit. Some people, you know, I had a patient a couple weeks ago who had been in pain and discomfort for 5 or 6 years, unrelated to cancer, a chronic progressive disease. Symptoms, just lots of suffering leading up to the end of life process. And for the last 2 weeks of life, she didn't take a pill, she didn't take a medicine, she didn't have any tremor, she had bad Parkinson's disease. That went away. She had no symptoms. It was one of the most peaceful processes I've seen somebody approach. And so I would say that's not exceptionally common, but there is no certainty that there's going to be a lot of pain and discomfort. And I think, you know, what we in the palliative care in the hospice world see is if we see discomfort, if we see suffering, we want to try to find some mitigation for that. The important part, though, is not all suffering and pain is physical. It's not all somatic, right? It's not musculoskeletal. Certainly might be emotional pain or existential suffering, or and I, you know, the reality is we're not going to know what the answer, what the true cause is, but we're going to try to find a way to calm that, because everybody deserves the respect and the peace and the dignity. And what I have found is when you haven't had, if there is pain, if there is suffering, if there is agitation, people have a hard time moving through the immediate end of life process, the dying process, if those are left untreated. And so lots of times we see this escalation of symptoms and we start to treat that. And I have to prepare people because by reflex, by human nature, people are going to point fingers at medication, right? Medication hastens somebody's death or sped this upward to death. But in reality, what we see is oftentimes when we can provide medications or even non-pharmacology interventions, if we can provide some peace and create an environment where there's calm and peace, people are able to move through that process in the time that's right for them. And so sometimes discomfort, suffering, or symptoms left unmanaged will inhibit that process. And it can become a long, drawn out process. And so, I mean, that's a long-winded answer to say that we don't know. I've had patients who have no reason to have pain, right? Dementia, no reason to have pain by the disease itself. And when they get to the last, you know, weeks or days of life, there's lots of discomfort. And so we treat it. And is that physical pain? I don't think that we're ever going to know until we get there. So I hope I've given, that's a hard question. And that's really, I mean, we could have an hour-long discussion on the philosophy behind that, but I hope that I can do that question justice. There was a question before then that is probably one of the most difficult things we encounter in the palliative world, and that is talking about nutrition and the body's, you know, so let me see if I can scroll back up. I don't know how to do that. Oh, I see. So as a family member or caregiver, do you manage the lack of wanting to eat or wanting to sleep all the time, or do you let it happen? That is the hardest question that people ask about this process. And I think it's really hard because culturally, we break bread with people, right? It's a way that we express our love and our care and our concern and our, I mean, you have friends and family over, you have a meal with them, right? I mean, culturally, it's a very important part of what we do. And so when we see people who eat who eat less and sleep more, and I don't mean to say that they come hand in hand, so let's talk about eating. It is a very natural process. It's the body's way of going through this. I always tell people that if you took an able-bodied person and you locked them in a room and you didn't give them food or water, they are going to die from starvation, right? If there's no other underlying illness and you don't feed them, that eventually will result in the end of life. When you have a natural process towards the end of life, that is, every single patient that I've had, regardless of the disease, will eventually eat less. And it's not because anybody's withholding it from them. It's because that's the natural process. They ask for less. When it's in front of them, they're less interested in eating it. You start to see the percentage of the meals they eat starts to go down. Their interest in eating in general goes down. And people struggle with that. And they say, well, if I can just give my mom some nutrition, if I can, she'll do better. If the disease process was as simple as providing good nutrition, we wouldn't be here having these conversations. And so, it's important to remember that when you're at the end of life, we've exhausted all of the appropriate interventions. And nutrition, caloric intake does not reverse a process. Being awake more and acting like they have more energy doesn't reverse the process. And so absolutely those things are natural. And I don't even want to say we just let it happen. But it's important to acknowledge that it will happen. And trying, I see lots of families who push food on their loved ones as they're starting to eat less. And we have to understand that there's a lot of anxiety that we're inducing from doing that as well, right? Now we're putting anxiety upon that person. We're making them feel guilty that they're not performing. And we have this thought that if you could just eat, you'd get better. And so it's a hard discussion. It's not taken lightly. I fully understand it, but it is one of the most common questions that I get. And I would say the same goes for feeding tubes, right? I mean, we've had people who have gone and insisted on having a feeding tube inserted, within the last couple of weeks of life, because you have to just feed somebody. I would say the body knows what it's doing. There is a release of endorphins when we go into a bit of a starvation state, right? It's not painful, and actually the endorphins counteract any discomfort. But if somebody's hungry, they're going to eat. If you put food in front of them and they're hungry, let them eat. And people may eat a bite of something and then put it down. I say, don't be surprised if this person has a request for food and you drive all over town and you pick up something from here and something from here and you come back, they take a bite or a sip and then they put it down. Because texture and taste is absolutely part of quality of life and pleasure. We don't just eat for sustenance, we eat for pleasure. And so we have to be okay giving that person the opportunity to enjoy that without the need to make sure we're clock watching the calories, right? And I would say as you get to the immediate end of life, we as humans are not working on caloric intake. The energy that we're working on is a different energy, right? As you start to have one foot in one world and one foot here, it's a different kind of energy. It's not nutrition that we're after or running on at that point. So again, that's a hard discussion to unpack. Dr. Geetha, I don't know if that's something that you typically have to address in.
Yeah, so, I just wanted to add in one thing is if a patient is on active treatment, I would strongly encourage nutrition at that point because they are taking something toxic, something to counteract the cancer, and they are trying to aggressively treat the cancer. Then I would strongly encourage nutrition. On the other hand, when we are on hospice or when we are trying to not proceed with active treatment, where they are solely geared towards comfort, if they no longer feel like eating, at that point, eating becomes like a chore. It becomes like an extra burden of work for the patient. And at that point, the body is trying to shut down, and the patient is feeling like it's asking them to run marathon, when they eating food becomes like an extra burden of work for them at that point. And that is the reason why they are no longer eating, because that is a exercise for the gut, exercise for the pancreas. It adds a lot of burden to the body, and they feel like they no longer want food. And so it's their way of conserving energy in a way that they don't want to eat anymore and sleep a lot. So in those situations, it is hard. It is hard for the patient's family because, like you said, feeding someone is a simple, like you said, we break bread and we entertain people with food, and it's a one of the simplest pleasures in life. So it is very hard to watch that. Certainly in certain cultures, it's extremely hard to say that you cannot have nutrition. Even in my own family, I've had to face certain situations like that. And so I think I always say feeding is a form of love, or you're showing care, and that can come in many forms. Instead of feeding them, hold their hands, put their favorite music, be there with them, talk to them. They are listening, and be there with them. That is another form of you're showing that you care. So instead of burdening their stomach with food, you can show care in many other forms. And form of nourishment. Nourishment comes in many ways, not always in terms of carbohydrates and proteins. And so, that is a way to approach family, and letting them know that we are not abandoning their family, we are not abandoning the patient. And just like we stop chemotherapy when it is no longer helpful, nutrition or food at some point is no longer useful. It is not going to delay the process of dying. It might prolong the process of suffering, and might cause even more problems like aspiration, or food gets stuck in the mouth with infections or other problems. So I would always say it's making sure that their mouth is moist so they don't have dry mouth sores. That is important. Oral care is very important, but not necessarily putting a tube that is going to be more harmful for them. And in most studies have shown that they have not prolonged the life, in fact, more harmful. So that is how I approach. But it's very important for the family members. As doctors, we have to listen to their family members, because we might see evidence-based science and we might have more evidence on this. However, it's a basic human nature to feed someone. And this is their own loved one in the hospital or in the home. And so as a provider, being patient, listening to their concerns, and showing them the evidence and guidance, through this process. It's a tough process. It's one of the process I feel like family members struggle a lot. And I certainly can empathize with them to some extent. It is just a hard process, and it takes time. You just have to be patient. And one of the biggest thing is do no harm to the patient. And I always say food sometimes becomes harmful. When it becomes harm, don't do that. And so that's the way I approach patients. But again, as I said, it is a hardest conversation. It's important to listen to the patient or the family members and not be judgmental on this, because it is a hard process, no matter how you explain things.
And I would say this really question was asked from a caregiver's perspective, and it's hard. It is hard because that's something active that we can do. And like you said, Geetha, it's nourishing, but in this situation, not healing. And I think ethically, absolutely never withhold something from somebody that needs or wants or is requesting that. But certainly not pushing. I think acknowledging, accepting, and allowing those people, the patient, to make their choice, and they'll let it be known. It may be not in words, but in actions. But again, I think we're not talking about withholding something. We're talking about acknowledging the fact that everybody will come to a point in life where they're not interested in eating, because that's not the nourishment that they need at that point. So That's great. There's lots that we can really dig into with that, but I want to make sure we cover some of these other topics. Cynthia, anything you want to add to that?
Oh, I just, the only thing I would say from a caregiver when I cared for others at their hospice bedside, including my mom and dad, it's so hard to me. It's so much harder to be the caregiver than the person going through it. Watching suffering, it changes who you are, quite honestly, to watch someone suffer that you love, anyone, but especially someone you love, changes who you are. It just flat out does. And so from that perspective, like Dr. Geetha was saying, it's just so difficult. But at the same point, I think if you can wrap your head in what helped me is you're not going to make them live long. You're just complicating things potentially, but it's just not going to make them better if they're in that phase, right? And so, but from a survivor perspective, and maybe I'm different, but just, I always like, how would you feel if you had the flu and someone was trying to give you food? If you didn't even have a disease, but you were sick with the flu and someone was trying to give you something to eat, you would be like, oh yeah, no. Well, I know, I mean, I have an appetite, but sometimes it's hard to find something I want, and like you were saying, it's just like, you might try this and eat 2 bites and say, yeah, that doesn't happen, so I'll try something else. And I'm not even at that end of, the last weeks or whatever, I don't think, but that's on me to just own as a survivor, as the person that going through it. So I wouldn't want someone, and thank goodness Dave doesn't do this, but I wouldn't want someone trying to shove food at me when that's the last thing I would want. It would make me cringe, right? You're doing the best you can. It's not like you want to not eat or want to not drink. And I remember feeling that way when I was going through chemo. It's like, I just can't. And you'd have to sometimes just go in for IV fluids because you can't, because you're not going to keep them down. So I would just say, do your best to empathize with the person. I think we can all do that. And that came to me with, you know what, if you had the flu and someone was shoving food down you, you'd be like, forget it. And so just try to put yourself in that as a caregiver. So.
Great. And I think with that, pushing food onto people inadvertently, sometimes directly, sometimes indirectly, we're creating a lot of anxiety, and we are creating a guilt from the person who's suffering already with decline and disease. It's a hard process, and nobody would ever minimize that. But I think that if we can acknowledge that this is a normal, natural process for every single human, regardless of why they're approaching end of life, I think that makes it a little bit easier to put into the context of what that person is going through. So there's a good question here, and then we'll move on. But it says, in some of the desire to not eat or sleep, is some of the desire to not eat or sleep more induced by pain medication, or would it naturally happen without the pain medication? It will naturally happen regardless of pain medication or anxiety medication or bowel medication, any medication. If people are hungry, they will eat. If people are not hungry, they won't eat. I have not seen any correlation necessarily with medication and a lack of appetite. I think you probably see that, Dr. Geetha, with chemo, but I would say that it's probably a transient, more like a transient experience.
In the earlier part of metastatic cancer, if a patient is not eating that much, we always try to look for a reversible cause. Either if they have a gastritis from stomach, some of the medication side effects, or do they need an appetite stimulant, or do they have a blockage or intestinal obstruction, or what's going on. And so you're trying to see, and most of our medications have side effects of lack of appetite and nausea. So is the nausea adequately controlled? Do they have cancer in the lining of the belly that is causing bowel blockage, or is that something that we could reverse it? But as time goes on, like, and we think it's not from all those things, it's just natural process of towards the end of treatments or towards the end of, beginning of hospice, or where they think no longer it is working. You see that as a natural progression slowly. And at that point, you may not be able to reverse a lot. And you just acknowledge the patient is going through this, and try to give them some tools. And I always say sometimes small frequent meals is somewhat helpful than a larger meal. If a patient has to eat a food, and if you give a big plate, one look at it, they won't eat. So I always say give them very little enough, and then give it more often instead of giving smaller frequent meals. I have seen that to be helpful. And all the shakes that nutrition, they taste awful. I have tried it, because before I recommend my patients, I've always, even the contrast, I have tried the oral contrast with one of my radiologist friend when I was in my residency. He teased me because as oncologists, we order a lot of scans. So, and he said, well, why don't you taste this contrast? You're putting all these things to the patients. Why don't you try it? And so he dared me. And so I did try, and some of them were very awful, I have to say. And it gave me a whole, I still order a lot of scans. But however, I have a better appreciation for what my patients are going through. Even some of my family members have gone through some MRI scans of late, and just, getting the IV poked and sitting in the, inside that, tube with a lot of sounds. It gives you a new perspective of what they are going through. But definitely, taste is something, and it's tough what patients go through. And it's a natural process. I guess I'm digressing here.
I would just add to that, yes, in my world, I have tools to stimulate appetite. I have, I would say steroids are wonder drugs in my world, but appetite stimulation is appropriate. But I go to the person and say, are you hungry? And they say, no. And I say, are you interested in being more hungry? And they say, no. Or they say, well, I'm hungry, but as soon as I eat one or two bites, I'm not hungry, right? So there's only so much that pharmacology can do. I would not stimulate an appetite simply because somebody's eating less. I would engage that person to see if it meets their goals. And it's not going to reverse a course. It may improve somebody's quality of life, and that's what I'm after. So, and to converse to that question about medications and a lack of eating, I actually find that the opposite is true. And if you have uncontrolled pain or uncontrolled shortness of breath or anxiety or nausea, those things will lead to a disinterest in eating. But if you treat symptoms well, sometimes people kind of turn back around and say, things as simple as poor sleep. If you don't sleep well, your pain will be worse, your nausea will be worse, your anxiety will be worse. And so rather than sometimes loading on a bunch of meds to treat each of the symptoms, we come back to the root and say, let's get you sleeping well, and let's see where that goes from there. So a lot of times I find that treatment of symptoms leads obviously to a better quality of life, but as far as eating is really can improve the situation. If you got a, right, let's take your example, Cynthia, of being ill. If you feel bad, if you have a lot of pain, if you got a fever, you're not going to the fridge right away. It's just not what comes to the top of mind. And so you treat people symptomatically, and I really see the opposite of that, rather than the pain meds causing that. So. Yeah.
And I want to add one thing: if the disease is controlled, automatically they will eat better. If the disease is not being controlled, no matter whatever stimulant we give, they won't eat. So a lot of this is correlated to the disease progression as
well. So the next bigger topic, and it's actually, I don't know that this might be a fairly quick one, but we're talking about what does an end of life timeline look like? I'm going to give a trite answer and say that looks different for everybody. I know that's not exceptionally informative, but that is very, very true. And And sometimes that process that we described of slowing down happens over 18 months. Sometimes it happens over a few months. Sometimes it's over a few weeks. And a lot of those things you may not even recognize are occurring until you look in hindsight and you say, you know what, I really haven't had, I really have been eating probably 50% of what I used to eat. And I'm sleeping 14 hours a day. That's not, but they don't typically happen like an event. And so you may not even recognize them. And so lots of times when we describe the end of life process, families are like, oh, we've been seeing that go on for some time. And not that we would have done anything differently, but that time frame is really hard to determine. I would say that we approach death in the same manner that we approach life, right? And that meaning as an individual. If you go through life and you're the life of the party and you're boisterous and you're greater, that's how you're going to approach the end of life. If you're reserved, if you're quiet, if you like alone time, that's how you're going to approach the end of life, right? I mean, if you're stubborn for the first 60 years of your life, you're going to be stubborn in the last 2 months of life. And so acknowledging that and recognizing it helps us meet people where they're at and help them through that process. So I just want to say that we tend to think that disease progression or decline kind of happens right like this in a linear fashion, slowly over time. As time goes on, things change. And that is true for some diseases. That is not typically true with cancer. And if I could graph it out, what I see is that typically cancer goes along until it just can't go in the same, and that decline sometimes happens quite quickly, right? If you look at other diseases like heart disease or lung disease or dementia, those are sometimes the runway is really long and it's a slow, steady decline. But what I find with cancer, and particularly in younger patients, is that you can kind of mask that decline, whether you're even aware of it or not, until there's a point where the body just can't mask it. And then you see sometimes a significant decline or a faster decline than we would all want. I'm sure, Dr. Geetha, you see that in clinic.
Yeah, definitely. Definitely, we see that in the clinic where there are patients, some of them, actually live even for years without much decline. And then there are other patients who they do well for a few years and then they decline, and then they get a little bit better with the change in treatment and then they decline again. So it's more like they're doing this and then they're dropping and then they're kind of in that second and then dropping, and then, it goes in that phase. And so it's kind of harder to, and the young patients are otherwise healthy, right? If you take away the cancer, they have the healthiest heart, healthiest lungs, if there is no cancer. So they don't have a lot of other comorbidities. So for young patients, it's exactly correlates with how much disease control they have. Whereas in older patients, it's not just cancer alone, they have other problems on top of cancer. And so that kind of, puts those things, one has to put those things in perspective and see how the decline happens. But definitely we see, and there's a fatigue of treatment, ongoing treatment. There's a fatigue of going through the motions of treatment. And sometimes if the scans look great or if they have a good response, but the patient is just tired of coming to the office and just wants a break. And that's sometimes you see that in young people, because they are not, they're not accustomed to coming to doctor's office at all. If they didn't have cancer, they would have never seen a doctor. Those are some of the youngest people I see. And then on the other hand, some of the older patients, they go to the doctors for their heart problems or their lung, other problems. And so those patients are so kind of do not mind coming to doctor's office that much. But young patients do struggle a lot with coming frequently to the doctor's office and need the emotional break from us as well. But the fatigue is a real problem.
Cynthia, you certainly don't have to, but anything that you want to add to that?
I would say when you talk about, progression, and what does that look like for what does end of life look like? Because that was the question, right? Like how long? What was the question again?
The posted question is, what does the time frame look like?
Yeah. And I think you're right. We don't have a crystal ball, just like, I mean, like you don't know, but I think there's a difference. And I want to really encourage, because I know there's quite a few metastatic survivors on the call and family members. And so much of this, when we talk about end of life or metastatic disease, it's like, oh, well, they don't have an appetite or they're more tired. And Clay, like what you were saying, if you look backwards, you can start seeing the slowing down. But they could have 2 years, like I've been slowing down for years, and I can look back and see that. And I can see that trajectory is getting steeper, right? Like I'm not stupid. I get that, okay, the first few years, I'm like, I don't even, other than pain, it's like, yeah, I got this, no worries. But then as it starts having more disease, the body reacts. I'm assuming, I'm not a doctor, but it's like I can look back and say, wow, this trajectory is sharper. And so, but I want to make sure that people understand it doesn't mean that, oh, because I'm a little more tired, that the end is tomorrow or 3 weeks from now, or even 6 months from now. That is so, I think that one of the doctors, they write, Dr. Geetha, you can probably answer this too. They do a performance index is what they call it. I didn't even know that was a thing. Right. And so if I'm blowing and going and I'm doing and I'm okay, even though I've got these problems with pain or problems with X, Y, and Z because of my disease, in all likelihood, I still am thriving and I still can thrive in spite of that. And so I want to make sure people understand that, okay, I slept longer for the past week because I was just tired and I have more appointments or this or that, but it's okay. But it doesn't mean just because I increase my time of rest an hour a day means I'm going to go in 6 months. You know what I'm saying? Does that make sense?
Absolutely. Right. I mean, it's a caution to basically say you're not, every symptom or every change that you experience doesn't mean that the cliff is right around the corner.
Exactly.
It's really important to understand because, and again, I just, I don't think we can overstate it enough. None of these conversations, this one in particular, we're not having this with, with the inadvertent side effect of provoking anxiety or fear, right? I mean, we're having frank and hard conversations.
Yep.
So that
one of the things I wanted, things I wanted to add is like, as the energy declines, energy is like a money in the bank. You have finite amount of energy for a day, and how you use it is very important for the cancer patient. So I always say, like, don't put all your tougher tasks in one day. Just break it into, if you're going to do laundry today, don't do the cooking. Or if you're going to do the meal preparation, then leave the laundry for some other day. And involve your kids in doing the chores, like make it as a fun part. Like, I didn't do it still with my kids, but if you guys can be successful, involve your kids in helping you. And if you're still working as a metastatic breast cancer patient, make sure that you organize and plan before you go for any meetings, and have reminders if you have a chemo, brain, or cognition impairment, and surround yourself with people who can help you out. And if someone can do the tougher chores for you, if you don't feel like cooking, and if your friends are willing to help you, you can assign, okay, this is the day I cannot, I'm going to seek some help. So kind of pacing your energy and how pacing your life, and those kind of things will be very helpful. I think just assessing your own functional status and trying to cope up with that. Your doctors will also to some extent give you a clue, but you have to be open to ask those questions of, as you get weaker and frail, how am I going to use my energy? That's a
that's a great point. And somebody had asked a question earlier, what are the strategies that you deal with the physical changes or the physical decline? And I think again, Cynthia, you might have some better insight, but the thing that I see, one of the most important things is energy conservation, just like Dr. Geetha is talking about. You may not have the strength and the energy in the get up and go that you did last week or even yesterday. And that's okay. I think acknowledging that and being able to lean on the people that you have in your circle is really important. Being okay, being cared for to some degree is important. And I think to your point, Dr. Geetha, if you don't have good insight into your energy limits and your how to conserve that, you go, and then I see people who are sleeping in bed lethargic for 3 or 4 or 5 days because they overdid it. And I don't, you won't learn and where that line is until you overdo it, and then you say, I'm not going to do that again. I know where I should probably stop. And in the same token, if you have an event that's coming up, you might keep the 3 or 4 days leading up to that event pretty quiet and mild, and kick your feet up so that you can build up that reserve and really go enjoy whatever it is you're going to go do. So again, we can dig into that, I think, but
and medically, your doctor should be looking into your the anemia from the chemotherapy, or adjusting medications to keep your energy as closest to your best ability as possible. So that's something as an oncologist, can I keep the hemoglobin somewhat decent, level that the patient has enough energy. And if the fatigue is unbearable, if I'm not going to cure the cancer, does this chemo is causing too much side effects? Should I back down on the dose of chemotherapy so that they can still, the goal is to keep them as functionally as best as they can. And so as a physician, we try to kind of change things on our end, how to do that, and then kind of teaching the tools for the patient to understand that you're not going to have the energy that you had before you had the cancer, and you're certainly not going to have the energy when you're on active treatment. And when we actually stop the treatment, the patient actually has some more energy because they're not actually suffering from the side effects of treatment. So for a brief period, when they stop the treatment, actually they have slightly more burst of energy, and then giving them some holidays in between of the treatment, letting them go and have vacations or enjoy what they have to do. Those are all the things to keep and underlying depression can cause less energy as well. If they have coexistent thyroid problem, we try to look at that. Some of our medications can cause thyroid problem. So we are looking at all those things to kind of micromanage from a medicine standpoint. But then regardless, when the patient has got finite amount, they have to learn how to pace themselves.
So there's one excellent question that just came. Oh, I'm sorry, I didn't mean to cut you off.
And they just have to, there are days where they won't feel like getting up, and that's okay. And they have to, post call, sometimes I feel like that. So it's okay to not have that much energy, and it's okay.
Our next topic I really want to get to because it digs into the philosophy, and I think, Cynthia, this is really where I think you have a lot more to contribute than Dr. Geetha and I, because it's coming from that personal perspective. But there was one question I want to address real quick. It says, and really I don't want to breeze past these, but I believe we have a hospice palliative care specific talk down the road. I might be wrong about that, but I know we have topics where we cover a lot of these things in future talks. But there is a question here is saying, is there a concern about taking pain medication to manage symptoms that it eventually won't work? I'm worried about when the time comes that nothing will touch the pain at the end. I would say that I would never guarantee anybody anything, right? Because we're talking about the human body, and we're talking about the human body at the end of life. But I will say there are very, very, very few patients, very few people that we cannot get their symptoms controlled. We have lots and lots of tools up our sleeve. We do lots of things in the hospice and palliative world that we don't necessarily do in the mainstream healthcare. So I would say that is not a concern. The concern is if you leave your symptoms untreated. I find more harm in people trying to tough it out for whatever reason than allowing that to be treated, because I see people become more functional and have a better quality of life when we treat their symptoms. So I would not hold off on treating your symptoms for fear that those medicines will become ineffective when you really need them. That's just not true. We do build a tolerance to those medications, and that's okay. We acknowledge that. There's lots of math and science in how you dose those meds. And no, I've never had a patient who used meds earlier and now they're ineffective. If something's ineffective, we rotate to something else. If taking a pill is ineffective, we rotate to using a pain pump. Or there's lots. I would say that's a great question. That's a great question to begin to have with your providers. And I would say specifically with your palliative and hospice providers, if and when you get them engaged. But I do not find that that's a concern. So just to kind of put that in rest a little bit.
And this is one thing I completely ask a palliative care physician or a pain management physician to help me, because I do think they have a lot of experience what works for each patient. So I definitely don't hesitate to ask for help for pain management with palliative care. And this is one of the ways we can work hand in hand and definitely help the patient quite a bit.
We have liquid medications, we have pain patches, we can compound topical medications that just get rubbed on the skin. We have, I don't really ever use intravenous medications because to start that route is painful and burdensome. We have another route called subcutaneous delivery of meds, and that's nearly painless. But the point is we have lots of options and lots of tools when it comes to treating symptoms. So that's a great question. This next big topic that we had posted, one of the questions is, what are my rights regarding refusing care? And Cynthia, I think that you and I have had some great conversations, and I think that there's some good points to be made here. I will just say that I don't even like to use the word refuse because that comes with a connotation. I recommended this and that person refused it. They refused it. I think it's rather a choice or a choosing not to pursue based on knowledge and information and education that's right for you. So I really don't even like to use the word refuse. It's a choice to not pursue treatment, or a choice to pursue a different path. I think ultimately we all have the right to conduct our lives as autonomous adults. And certainly we all deserve to be treated with respect and dignity and love and kindness. And I have not yet met a soul that doesn't wish that for themselves. I think that death is a part of life. It's a natural process. It is sad, absolutely, but it's natural and often need not be tragic. And that's really the one of the points of this topic, is that you always have the right. None of this is a binding contract. Even if you choose to do something on Monday, it doesn't mean that next Monday you have to continue to do it. Now, Dr. Geetha might tell you, she might have to give you a pep talk and say, I get it's hard. This is burdensome. It's causing all sorts of symptoms. Let's get through to the other side because it's going to look different for you. That certainly is a valid, legitimate conversation. But if you have gathered all the information and you feel for you that going down this path of treatment or disease-oriented interventions is not for you, you are well within your rights, legally, ethically, morally, to not pursue those things. And again, I think I relate death to birth, and in fact, it is another birth to me, right? It's another active process. It's a transition, and we all deserve to leave here in a similar fashion to our arrival, with love and care and attention and energy and medicine and all of that comes with that. And I do think that we can approach the end of life with grace and with dignity, but I think we sometimes lose that opportunity if we avoid the hard parts, which is planning and discussing. And so your rights are your rights, right? There is no paternalistic entity that forces you to do anything that doesn't feel right for you.
Yeah, and I would agree to that. And, yeah, you know, even in curable cancer, sometimes patients refuse to get treated. And as long as a physician, if I have counseled them adequately and they are aware of their options and they're making an informed decision, the decision is theirs. And in medicine, we practice like patient autonomy comes very important, that we don't have a paternalistic attitude. And we act in beneficence, that we are thinking that this is going to be in good faith. We are going to do, you know, do the best that we can for the patients, and do no harm, and treat everybody with, you know, equity equally, regardless of their faith or their gender, race, and everything. So these are the 4 principles in medicine when you treat a patient. Give them the respect, give them the informed decision, let them make the choice. Try not to do any harm to the patient, try to act in the patient's best interest, and try to treat everybody equally. And that's a philosophy of, you know, medical care, as, you know, at least here.
Cynthia,
My perspective on this
yeah,
is really strong.
ask a question, but I think just go for it.
I'll go back to the hairstylist. You know, it's just like, if you don't want it to be red, you choose brown, or I mean, like, if you're going to make choices, you make choices every day in your life. Why would you give the choice over life to someone else, right? Like, you have a right to choose your doctors, your healthcare team, your family, your friend. I mean, like, everything is a choice. And so we live, fortunately, to where, you know, we aren't mandated to get care or not. And it's as simple. When I saw that question, just say no. You can say no. And I can't speak for doctors, but it's like, I've never had one of mine, and we've said no a lot, but not without hearing the input and the education and the knowledge that the doctor is recommending, and saying, okay, we recommend this, A, B, and C, or these are your options. Then we get to go back and digest that, and then say no if we choose to, or it's yes. It's either Boolean, it's either or, you know, 1 or 2, you know, however you want to look at that, A or B. It's either yes or it's no. And what we've learned, and I'll share, just like, you know, the example we were talking about earlier, we're dealing now, a couple of months ago, we found out, I started with kidney failure, and they don't know why. And so that's progressing to where it's already the trajectory is pretty steep, and it's stage 3 kidney failure, and they don't know why. They have no idea why. And they're recommending a minor surgery, talking with the docs. And it's like, they know me, and they know that I'm like, is this worth doing? Right? Because I still don't want to give up good days for bad. I don't want to be uncomfortable if the solution is stents, and I have to deal with that every 3 months. So it's like, let's talk about this, and let's have that discussion and get the information. And my husband and I will make the decision, and it's ultimately my decision, but it's with my husband's counsel of batting it around. But that's one of those situations where it's just like, I can say no. I can say, you know, that doesn't work for me. Is it an option to do labs, you know, every couple of weeks, and just watch it and see what happens? Or is it super emergent? So yes, you can say no, please. As a survivor, as a patient, and as your own advocate, we worry about way more. And if you're worried about that, that's not something I think we should worry about, because Clay, to your point, we're still paying for a service, right? And so you can say no. And so I feel strongly, and I don't feel like my team takes that personally. But I go back to, I chose my care team, and I feel confident in what they're recommending, and they understand me. I understand them and where they're coming from and appreciate that, but I still can say, I'm opting out, right? And I think what I've learned that works for us also is we ask for an out clause. We just do. It's like, if I start this, are you going to give me an out? Because what if this makes me really sick? Because it takes that stress and anxiety away from that decision factor, and say, okay, I can do that for a week if it's going to gain me potentially whatever it is to gain, whether it's managing my symptoms, whether it gives me longer, prognosis. But I can say, what's my out clause? And being armed with that information, just like we talked to the specialist, and I'm like, what's my out clause? And he's like, I'll take them out if you're miserable, right? Like we were talking stents. And so I'm comforted knowing that I'm more willing to try something and not feel so good for a couple of days, even if my benefit potentially is there. But if I have an out clause, and he'll go take them out, right? So I think that just say no. And if you've got the big root underlying message I would have there is your care team, you have to trust. You just have to trust and have that relationship with them. It's not just going in and, oh, check in, got my lab work, I'm done. Even if you trust them, that relationship needs to be solid, so that you can be forward and straightforward and very direct, because they aren't mind readers, right? Just like I'm not a doctor, they're not in my head living my life. So it's up to us. And Dr. Geetha and Clay, you can please chime in, but I would think y'all need us to be that direct and that frank and candid.
Yeah, that's really helpful when the patient knows her goals very clearly. It helps the doctor to help them achieve that goal. Yeah. And, as a physician, we give them options, the choices, the pros and cons, but ultimately the patient gets to decide, because it's their life. And we always wanted to know what their thoughts are and where their goals are. And sometimes they change their goals and as they go along, and that is fine. And we always wanted them to do that. And I also, you nailed a very important point, like what is my out? And so sometimes patients are so nervous to start chemotherapy because they think once they signed up, they're going to do it forever. And so they're so scared. And I always say, just if you do one treatment, if you don't like it, let's stop the next week. We don't even need to do it. And so that part is sometimes for them to know that they can always say no to us anytime during the treatment. Of course, it comes with the consequences.
Yes.
Of not doing the treatment that will result in progression of the cancer. And as long as they are at peace with that, yeah. And they're okay with the choices that they are making, we'll absolutely support them. It is a hard process, and it's important for us as physicians to give them enough information. And it's important for us to be patient, because we do this all the time and we are reading all these things, but we are not living their life. It is their life. And so I have to always remember going, that patient has got a whole life before they saw me. Their mother or a sister or a friend, they had a bigger role, and they're all reduced to one stage for breast cancer patient, but they have a personality, they have a mind, and they have a thought, and they know exactly what they want, what they don't want, and where they're coming from, the kids. There are so many things. And sometimes patients make vacation choices, doing things, and they have to do it. And so while we know that they have to delay their treatment because they're going on a trip here and there, I have to remember that they're living their life. And sometimes I joke around, hey, you need to be on trip. I'm missing you too much. You have to come here. But I also have to acknowledge that they have a life outside the cancer center. And that is the most important life. And all we are doing is to make sure that the life outside the cancer center is as lively, as best, as full as it can be. And our job is to make sure that it is not centered around the cancer center, but it's centered outside there. And that is, I take a lot of cues from the patients, because it's a two-way traffic, and the patients educate us a lot the patient's perspective changes us as physicians. And, I learn a lot from patients every day, what they say, even side effects for that matter. Sometimes some side effects are not mentioned in the literature, and then the patients start saying that, and then we go back and read more, and then we find, oh, this is a rare side effect these patients have, so patients teach us a lot, certainly, and they help us to also understand, when we first see a patient, we do not know their goals, and we are slowly understanding. So it's an evolving process. As I know the patients more and more, as we spend more time with them, they clearly teach us what they want. They clearly tell us how they want to proceed. And it's important to be patient. It's important to listen to them and then take the lead. And they are the ones who are leading us at that point.
Go ahead.
No, I think that if you're sitting here and you're tuned in, and again, going back to that caregiver team, if you don't have a doctor that does what Dr. Geetha just described, it might be time that might not be the doctor. You know what I mean? Like if you don't have that relationship or that trust with that doctor, that's what you need, then it's time to look for a doctor. But I don't want to make it seem simple when I say to just say no, because it's not. It is so hard to say no. And there is so much associated with that no. And, Dave and I have certainly found ways that when we get to that no, we feel confident in that no. But it's hard. There is a lot of guilt associated with that. There's a lot of stigma of, well, you're just going to say no and you're not going to be fighting this anymore. You're giving up. There's this and that and the other. And that's not it at all. It's an empowering thing for me to just say, I know the consequences. I know my body. I know me. And I have to, for this choice, say no. The next, I'm not saying don't bring other choices to me or other options at another, whenever it's applicable. But it's really hard. And I think maybe when someone asks that question of, can I refuse care? I think so often families play into that, right? Like you don't want to disappoint at your family and you don't want them to think that you're giving up and you want to fight that fight. And that goes back to in the first conversation where we just said you have to have these hard conversations with your loved ones and the ones that you trust, because it's so hard to say no. To get to that point of no, it's hard. I don't want to make it seem simple because it's not.
I want to pick up on something you both have said. You have to be aware of the consequences and be accepting of the consequences of whatever decision is you're making. I would say that we have no perfect pill, right? A perfect pill, 100% effective, 100% efficient, no side effects, and it's free, right? I mean, I wish. And
Me
so
too.
with all of the things, but I think the really, really hard part is you don't know the consequences unless you ask the right questions. And one of the hardest things that I help counsel people through is the questions to ask to get the information that you need to make those informed decisions. If you're waiting to be, and I no disrespect to any oncologist, by all means, I'm friends with lots of them. Lots of them are not approaching this like Dr. Geetha does. And so I think if you oftentimes have to ask very pointed questions, they will give you that information. But oftentimes in the clinic, there's so much happening. There's so much to take care of. There's so much to plan for that conversation may be not unwrapped as much as it needs to be. And so I think, Cynthia, you have an excellent perspective. I mean, I can tell you the things that I counsel people on the questions to ask, but I think you have an excellent perspective of when you walk into an office, whether it's day of diagnosis or you're walking into urology because you've just gotten new news about something that's being asked upon, what are those considerations? What are the questions that you would ask your providers so that you can walk away and go home with Dave or whoever your support circle is and have those discussions and make those decisions that are right for you?
Yeah, we just went through that this week because we met a new doctor. And for me, it was right off the bat, what are you seeing? What is the goal of this meeting, and what do you understand the situation is, right? Like, I want you to understand, have you talked with my medical team to understand what my goals are related to my life and the situation I'm in? But what is your diagnosis? How can you help? What are the options? And what is my out clause, right? Like all of those. And are there other options that after I digest, can I email you through the portal, or if I think of something? So it's really focusing on communication and making sure I understand what he's saying and what the recommendations are. But the biggest thing right off the bat is don't do to me. I mean, Clay, you and I have talked about this before, and I'm, as you progress with this disease, there's a fine line, like you've said, and I love the way you say it, but it's, I don't want to be done to, I want to be done for. And as you progress with this disease and things start going south a little bit faster or a little bit more, and there's just something else, right? It starts feeling like, okay, I'm being done to. Really, this is just something else. But I also say, what's the ROI? The first question I'm asking is, this really, do I need to do this based on where I'm at in my disease, and how is this going to benefit me? I call it an ROI, but I think in the medical world, it's, I don't know what y'all call it, but I mean, is there a return on this investment that doesn't cost me a lot? Because you're going to have to convince me to do anything. I'll be honest, like, you will have to convince me that this is a benefit. There is a return that this could help my quality of life. And if it does, what does it take to get there? And whatever it takes to get there, can I get out of it? Like, those are literally the questions we ask. And if they're not willing to take the time to answer all those questions and be frank, then I need to move on to another doctor, because those are I call them knockout questions, right? If they're not willing to listen to what my goals are with my life and my treatment, that's number one. Number two, if they're not willing to respond and answer all of my questions, I get everybody's busy, but I come prepared, and I want to really encourage survivors, and their families can help them. We have to own our own health to some degree, and we are responsible. If we want our medical team and caregivers to be great, we have to be great patients, and we have to be great. I mean, and we've got to try at least. And so I can't, like I said, they can't read your mind, but I have to learn to communicate with them and give them the chance to communicate back with me what I need. Otherwise, there's no way you're going to be, I don't know how that could be successful. It's never been successful for me. So I can only speak from that perspective. Did that answer the question, Clay? I
thought it was great. I mean, really in medicine, you say ROI in business, or return on investment, but in medicine, we would probably phrase that as risk benefit ratio. Like, right. I mean, when the risk starts to outweigh the benefit, obviously that's the wrong thing to do. Back to Dr. Geetha's point, right? I mean, first, do no harm. Well, if that ratio is out of whack, you're doing harm. In my world, I certainly have a consideration for risk and benefit. But I orient the conversation more to burden versus benefit, because I think that helps put it in perspective. I don't know why we save that conversation for the palliative world. It really should be an approach that we all take. But what is the burden that this proposed intervention comes with, and what's the potential benefit? I mean, that's the overarching question you would like to extract from your providers.
Exactly.
And so when an oncologist says, well, we can do this treatment, right? I mean, what I'm asking people to ask their oncologist, and I'm really asking legitimately, please get this information, because it will help me help you have a better conversation if you and I both have this information. But if there's a treatment being offered or recommended, my next question would be, how hard is that treatment? How is it going to make me feel? How bad is it going to make me feel? How long is it going to last? And what, in best case scenario, are you hoping to achieve with that, right? And the follow-up question to that is, if I choose not to pursue that, what does that look like? And now you have something to weigh. right? I mean,
Mhm.
if Dr. Geetha says, well, I have a treatment for you, it's going to make you feel horrible, but it's going to be 2 weeks. And in best case scenario, that might give you another 18 months of life. And these are not real numbers. I'm just throwing it out for example. Well, feeling crappy for 2 weeks is probably a pretty good ROI for another 18 months of, if that's quality life. And then if she says, but if you choose nothing, your length of life is probably 3 months. I think we probably would all jump at that opportunity. Feel bad for 2 weeks, get an extra, 12 or 13, 14 months of life. If the less divide there is between those outcomes, the more consideration we should really think about what that looks like, right? If we say, well, with treatment, we think we could give you another 3 months of life, but you're going to feel horrible for 6 weeks. And without treatment, you're probably going to have 2 months of life. So now we look and say, well, we've gained potentially best case scenario, 6 weeks of life, but I'm going to spend more than half of that in bed feeling bad. And so again, I don't want to think those aren't real numbers. I'm just using that as an example, but that's how I start to think through it. I mean, what you're offering, what's the best outcome, and what's the burden it's going to place upon me? And if I choose not to do that, what does that situation look like? And I think now you start to get real information that you can go home and sit down and have a conversation about. Dr.
Hey, can I intervene on one thing?
Please.
Many years ago, metastatic breast cancer had only a handful of drugs. So this was very clear at that time that if a patient had there are only A, B, C, D, and E drug, like 5 drugs. And if they failed one drug, we know that there are 3 drug options and each one might prolong a life. So we are able to give a overall survival pretty clearly. Now with all these nuanced treatments, it has become more, it is in a way better, but it has also muddied the picture in a way because it's more complicated. And unfortunately, it has become way more nuanced. And so it is so hard to project for us in a way. And if your oncologist is a little bit struggling with telling you how much response, they might be able to tell you for that drug, well, you have a 30% chance of responding to it. Or, but how long you will respond, only we do not know. Until the first set of scans, oh yeah, great response. Second set of scans, no, it progress. But one other patient will have 2 years of the scans and no progression at all. So that is the part we are struggling as oncologists, and I want to be very honest here and say that to the patients. That's a real struggle as oncologists we are having because no 2 patients are the same. And in the same patient, I do not know why one drug works for so long and then suddenly stops working. And then the next subsequent, all the drugs are nothing is working. So that part is so erratic and the cancer is developing more and more new mutations or resistance. And so we are actually struggling, which is not fair to the patients. But I just wanted to be out there, we are able to some extent estimate, but with all these nuances, with new treatments, immunotherapy or targeted treatments and new clinical trials or along those things have changed the paradigm shift. And at that point, we are kind of asking a philosophical question. Do you want to be more aggressive with all these treatments? And I'm not able to give a definite answer with if you do these things. I wish I had a more clarity of you will get this there, but I don't have that clarity because your disease is kind of constantly. So that's where we depend on the performance status of the patient and what the patient's goals are.
Right, and I would say that's where you say, well, the scans look great, right? But you look at the person and the person doesn't look great. And so, scans can only show us so much, labs can only show us so much. And conversely, they might look horrible, but this person, I feel better than I felt in 7 years. And so, well, I mean, all of that is information to have that conversation. And it's absolutely valid, Dr. Geetha, that we don't have all the answers, right?
This is evolving it's amazing how this is evolving as we speak, and every year we learn new things. Every year I learn new things, and sometimes I'm amazed at some patients who I think will not do very well, and they surprise me, and some patients where I think they'll do fantastic and they surprise me in a different way.
I think this conversation right here, this little piece is a really important, even if somebody left the clinic in didn't have, there isn't concrete answers, right? Like you said earlier, Cynthia, we don't have a crystal ball. And I think what I find though, is I find patients and they say, well, my oncologist wants me to do this treatment. And I say, well, what do you want to do? And they say, well, what option do I have? Okay, well, that tells me you've not had any conversation.
Yep.
Or at least you haven't gotten information you need to help work through that. So you may not have an answer. And the questions that I'm trying to arm people with, and they come in and ask you, Dr. Geetha, you may not have an answer. And I'm not saying that to put anybody on the spot or I mean, we're humans. We're working within the confines that we can. But I think if we haven't asked the question, how bad does it make me feel, right? What's the potential benefit if it works? And what does it look like if I don't do that? And those three questions, I think, help you get to an answer that's right for you. And Cynthia, you know, again, I don't want to divulge and I don't want to share your personal information, but you were presented with that, with an intervention, right? And you asked those questions. How hard? What kind of procedures, what kind of deal? And the guy's doing it is like, it's no big deal at all. Well, it comes from a guy who's doing 40 a week. Right?
Yeah, exactly. I'm like, you're not in my shoes, man. It's like anything to me is a cost, because I think if I could arm people, nothing is for free. No treatment, no pill. No, I mean, there is a consequence to anything that, in my opinion, that my experience, let me just say my experience, there's a consequence to everything, right? Like, you know, have I made decisions that I don't want to take a pain pill because they make me nauseated, but then I'm choosing to be in pain? That's my choice, right? But there's a consequence to both of those actions, whether I take one or not. And I know that's very simplified, but everything, there's a price to pay for the choice that you make. And I think I wanted to add here, and I think it was something we were discussing before the call got active. I think part of the challenge of living with metastatic disease now for basically 6 years is it gets harder the farther out I get, right? So sometimes it's not about, or is it, and it depends on the individual, I guess, but do I want to live that? I mean, I want to live, don't get me wrong, but am I just taking treatment to extend my life, but that quality of life based on where my cancer is? I mean, having it from the top of your head to your toes and your bones is no fun. I'm just going to say it's awful. And so managing that long term has been a challenge. And I've been fortunate to react really well to a couple of things, but not always. So I think that I see in the future from a survivor perspective is a question that we're going to have to dig into further and say, well, yeah, it may prolong my life, but at what quality of life? Because is it really, you know, and that's where the no crystal ball comes in. You don't know what it's going to do. So when you go in, it's like, well, it could do this, but if it doesn't, what did I pay? Right? What was the price that I paid? So that's kind of long-winded, but it's certainly, I think, a challenge as we go forward, as we live longer with this disease.
Cynthia, you said it perfectly. You said it perfectly, because that's one of the things, like you said, you know, we are treating with the intention that it will help, and certainly the patients acquire the side effects, but it is not helping them either, and that is the most frustrating part. They endure all the side effects without reaping any benefit sometimes, and that is a real possibility. Yeah. And understanding the patients, like you, saying what they want, what they're willing to put up with, and what they're not willing to put up with, will help us all be better doctors for sure.
Yeah.
Got a couple more. We have gone a lot longer than I anticipated we were, and that's great. I mean, it just shows that these conversations are hard, and once you get going, like they just start to unwind and lead to places that I think are beneficial to everybody watching. So I hope that there's value being taken away from this. It's certainly valuable for me. One of the bigger topics that we had listed is, what are the coping strategies handle the progression of physical decline. I think that we probably have hit on a lot of those. I might take away the physical decline part and just say decline, because I think, I don't want this to come off glib, but I think that cancer gives us an opportunity to plan, right? I mean, you don't have an opportunity to plan and do the things that we're talking about if, like you said earlier, you walk out and get hit by a bus, right? You had no opportunity to talk about closure. You didn't have an opportunity to get your finances in order and to talk about your advanced directives and to prepare your family and to do whatever it is that needs to be done. And so there's lots of opportunity for planning. I think if we can demystify and destigmify and make less scary the conversation, it provides us all an opportunity to approach the end of life in the manner that we would like. And what I see people at the end of life, it's the loss of independence and the perceived loss of control that is sometimes the most disheartening for patients and for people. And that perceived loss of control often comes from a lack of planning or preparation or conversation. And so I'll just say that's all I want to say about that. Cynthia, you can answer better the question about coping strategies. We may have already been through that. We don't need to be repetitive if you feel like we've covered that. Dr. Geetha, certainly if you have something to contribute, by all means, please do.
You know, I would just say that whatever works for you, quite honestly, it may not work for me, but it may work for you. And I know that some people, I'm a really I will completely admit that having purpose to get up in the morning and stay active mindfully and to be some way staying busy, but intellectually stimulated is that something really important to me. And so I have to make sure I put myself in those positions. It's proactive and we have to, otherwise what I've learned is that I need to, if I don't want to be half of me, and I'm not 100% me because of the progression of the disease, right? I'm not going to be what I was 10 years ago or whatever, but I can still be an active, viable, and live a purposeful life. And so I think I have to do whatever is comfortable for me to do that and challenge myself, because some days are more challenging than others, but it's possible, right? And it's a choice. And I think that's throughout the whole conversation tonight, you get to choose. And so it's sometimes not easy, but whether it's your faith, whether it's your friends, whether it's your job, and sometimes it's looked at, and I found that someone said to me one time, you stay busy to deny, right? No, I totally own that I stay busy, because if I stop, my pain gets worse. My mind is just sitting there with the pain, and it's not that I'm denying it, but it is a coping skill that I use, because why do we think pain goes up at night? Our body and our minds starting to shut down and rest, right? Well, your pain didn't get maybe worse at night. It's just been there all day, but you've stayed active. So for me, that works. Not everybody, but I think if you sit with your mind idle way too long, it doesn't work for me. So I would just say that there are numerous coping skills: prayer, meditation, being active. And even if you can't be super active, you can find something, right, that works for you. And so I think we as survivors have to own that.
I very much like your statement that it's a choice.
Yep.
Right. I think be an active participant in your plan of care, in your healthcare, because the reality is your care team, your doctors, whoever, those people go home at the end of the day, and they go and they visit their family, and they care and love for anybody that comes in the clinic and who's there as, you know, in their patient panel, so to speak. But but absolutely take an active role in this process. And I think the hazard of not taking an active role, and it's hard to take an active role. You need to advocate for yourself, and you need to have people who advocate on your behalf. If you do not take an active role and you rather take a passive role, what I see is that you probably will end up getting done to, rather than done for. And it's hard to recognize where that line is, but I know it's easier to identify it when you're actively involved in that process. The only other thing I would say, and then Dr. Geetha, I'll give it to you to see if there's anything you want to add, but the other thing I see that people really, I think that we could all do better with is allowing people to help. Allowing, and I really, was it Mr. Rogers that is said that you always look for the helpers, right? Because they're around and there are people willing to help. Sometimes they're not going to insert yourself into their life and keep asking you if they can help. And so I think being okay, acknowledging that we're human and we need help sometimes is an important part.
Yeah, and I think that is sometimes very hard for patients to ask for help, because these are independent women. They have done a full-fledged active career, and they have done all the things by themselves. They are multitaskers, and suddenly they are needing more help. And sometimes they still do all the chores like they were doing before on active full-dose chemotherapy, or doing so many things with extensive metastatic disease, and they forget to pace themselves. And I always say it's a finite reserve, so use it judiciously. You have like $10 and that's it. You've spent. How do you spend those $10 in a day? Depends on whether you want to spend 5 times, or you want to spend 10 and then take it easy. So it's very important for patients to pace their, and then try to find some ways to, most of these patients have neuropathy. So how do you, when you cook, you have to be careful. Even simple things like that, simple tools, if you're unstable, make sure that you have a shower stool, or make sure you have handles in the shower, like simple tools, like, do you have a, carpet in the bathroom, you don't want to slip on water, and you have to be careful with each small things, and try to minimize all your activities on one floor if you don't have a lot of energy to go up and down the stairs. But go for exercise. If you feel like going for a walk, go for it. Don't try to walk on the snow if you have a lot of neuropathy and you're struggling, you feel unstable. So those kind of, baby steps to know their limitations and what they can, and find things that you love to do, like find some joy in what activities that make you happy, and do something for yourself that makes you, either going for a coffee with your friend, or going for a walk, or doing some voluntary work in church, and find some meaning in all this horrible process that you might going through, but find some meaning and from joy. Sometimes we all have to look at we are all mortal. At the end of the day, we are all human beings, and including doctors. None of us will live forever, and none of us know the perfect answer, because no matter how much science is advanced, we have not designed a human body in a lab. We have not designed a cell. We do cloning, but we haven't designed a cell yet. And so we will not be perfect as doctors. We have our own limitations. We are learning, as we know about COVID, we are learning how little we know about medicine and science. We are getting better each day, but we are not perfect. And as doctors, we have to acknowledge our own limitations in terms of not able to help the patients completely. And it is a tough process, even as oncologists, because we are thinking that here we are going with enthusiasm and idealistic attitude to become a doctor, and here we are. And then when a patient's cancer progresses, it also feels like a slap on our face, and it also feels like we feel defeated as well, and kind of acknowledging our own emotions in this process, and making sure that our patients, we are there for our patients, but we are not God. We are not designing everything. And that kind of puts things in perspective, at least. And in this journey of life, it's a circle of life. We start somewhere and we end, and how we end, where we end, who we are surrounded with, all those things we do not know. But in a cancer patient, the anticipatory grief will be there even initially, but I think if you can find some peace in that process, whether it is through faith, friends, family, and leaving some sort of a legacy, and each patient leaves a mark, whether they know it or not, in someone's life. Sometimes they are very aware, sometimes they are not aware, but every single patient leaves a mark in someone's life. I always wanted to let them know. They may not remember that, but they always have some, they teach us something that I take home with, like some excellent points Cynthia made today. It does help us all to approach life in a different way. In the end, I feel that is a way to move forward. Patients who submit themselves for clinical trials that move the needle forward. I think that's an altruistic nature of a patient, who's sometimes patients say, it may not help me, but I'm willing to participate in a trial because it might help someone else. And to me, that's very humbling. To me, science exists because of patients, because someone is willing to take the first drug, unknown drug, and help millions of other patients that follow through. In a way, I think this journey is hard for patients, definitely. And but their resilience and their strength and courage give us more hope for doctors to move forward, to move the needle a little bit better with this dreadful disease. We are not there yet. We still, every time it's a setback. You see cancer progresses, but like Cynthia said, it's a journey that we all have to walk that walk, through cancer or old age or through diabetes or high blood pressure. At the end of the day, we all have to walk that walk. How that journey will be is different for different people. And we hope to make that as a long journey as possible and as an easy journey as possible. But we are not perfect, certainly, and that is a struggle as doctors. We all have to, it takes a lot of time to acknowledge that, even in our own personal lives, whether it's our own family members who go through that process of, death, or with our own patients. But it is a reality, and it is for everyone in the world. No one is exempted.
No.
That's very well said. Thank you for that, Dr. Geetha. And I would say, when I brought up earlier, look for the helpers. I think Project Pink is an organization of helpers. Right? This whole organization and the programs and all that it provides for the community. And Cynthia, all that you've done, they're all helpers, and they're all volunteers. And this organization proceeds with purpose and intent, and it's filling a void in the community. And I bring that up because I think we have lots of resources in our community. We don't have enough. And I think ask if you need something, ask. And if there's a support group or an organization or something that is there to help, let's figure out how to get you hooked up with that organization. And if there's not, you might have just discovered and validated a void in the continuity of support in our community, just like Cynthia you did with Pink, and then grassroots, you create something because people are in need. And so I just bring that up because obviously I care and respect the organization, but really because this organization exists because somebody, Cynthia, found a hole in the support network and what people were needing, and so it was created. So we have resources, we don't have enough, and but I suspect that we probably have more than most people recognize. They're just sometimes not easy to find, and if you ask enough people, you'll find, I think, what you need.
I would recommend, yeah, I would recommend, metastatic patients to be patient advocates in cancer conferences or in other active meetings nationally, because they move the needle forward. We didn't have a lot of clinical trials for cancer patients with brain metastasis. They were always excluded in the clinical trial. And of course, then we would not have any treatment options for these patients. And I still remember 2 years ago, one of the metastatic breast cancer patient openly asked why they were excluded and they should be included in the trial. And it was very poignant moment at that time when she was very specific. And so patient's voice is very powerful. Not just for treatment, but like you said, in terms of quality of life, in all other matters with regard to cancer. So patient's voice are very powerful, and I'm hoping Cynthia leading this way is very helpful. I think it allows patients to say what they, she set the expectations for the patients to ask the questions, to say, can say no to treatment, can say what you're getting and what you're getting out, and understanding that you can stop the treatment at any time if you feel like it's no longer meaningful for you. Those are all the take-home points, I think, for the patients to know that they can have those conversations with their physicians, and they have the project team community supporting them. It is a harder conversation for all of us, but I really thank Cynthia for and Clay for leading this and definitely helping us.
Thank you so much.
Thank you. I would just, it's been a pretty heavy conversation. It's a heavy topic. It's always great to leave with some, not that this is not a negative discussion by any means, but something positively or inspirational, and maybe that's misplaced at the end of this conversation, but I tend to think not. And I would just, I guess my parting statement would be that I typically see two kinds of miracles in my work. One of them is where people get medical recovery or improvement when there was no expectation that should be happening. That does not happen very often, not nearly as often as we would like that to happen. The more common and humbling miracle that I get to observe is watching somebody make peace and come to peace with the reality of their diagnosis, and going on and being able to live meaningful, fulfilling, quality of life existence with that information. And that's from somebody who's not gone through it, but somebody who holds a lot of hands going through it. That's a very humbling experience. And it's a beautiful process. And Cynthia, again, I know we're not here to highlight your experience, but I think you're a really, really good example of how well it can be done. And kind of with what grace that you can move through this experience. And so I just would like to say thank you for sharing your personal story. It makes this conversation so much more meaningful and valuable, I think, both for Dr. Geetha and I, but also I think for everybody who's tuning in at home. And Dr. Geetha, thank you again for joining us. Always an honor and a privilege to be able to sit and have a conversation with you. So.
And thank you so much, guys. As I said, it's always nice to hear from Cynthia what, she gives a fresh perspective every time I listen to her. And
might be a little too candid sometimes.
No, it does help. Like, at the end of the day, you're saying what patients are thinking, and that does help us a lot. It does help us to become better physicians, definitely. And knowing the science is easy, but being a doctor is hard. How you practice science. That's why medicine is an art, using science, I guess. So that is something that we can continue to refine and be better at it.
And I think my 2 cents at the end of this is, science can tell you statistics like we were talking earlier. I remember when I was re-diagnosed, it was like, or, even the first time, it's like, oh, okay, the average statistically lifespan I will get, my prognosis is X, right? But gosh, if I would have crawled in a hole and believed that statistic, what would my life have been like and what would I have given up? And I'm now literally 6 years into what should have been a little over 2, right? So it's humbling from that perspective, because I look back and I'm like, oh my gosh, what if I just would have just crawled in a hole, And so we're not a statistic. I guess as a survivor, what I'm trying to say is the statistics are there. The science is not perfect. We're all individuals. And we say this a lot, and we just had a young survivors retreat and they were all under 40, which breaks my heart. But life is for the living, right? We wake up and it may not be the day we want, but it's the day that we have. And if there's, I would just encourage to live that day. I can't think about tomorrow. I can't think about 3 days even from now, but I've got what I've got in that box of chocolates today, like everybody else, and do the best to make the best of it, because you get it, right? You get to. And so that's what I would hope is you're not, Melinda's on, I'm sure. And we joke, but I'm like, you're not dead yet. So live, right? The best that you can. So I hope that we are giving you the tools to help you do that. So.
Well, Cynthia, I think if the manner in which you approach the situation in the conversations that we've had on camera and off camera, I mean, if you could teach people how to do that, I think as a community, as a culture, we would be better. And ultimately, that's really what we're trying to do, right? I mean, this is a really, really hard. We're talking about a cultural shift, and I think the only real way to do that is to observe people having real conversations. And I think when people get off tonight, they're going to have lots of questions, and that's okay, right? I mean, write them down, share them with people, send them to us. We're coming back next month. We're coming back the month after that. We've got lots more topics. We're going to talk about advanced directives and financial planning and religious and spiritual considerations, and we have a whole list of things that we're going to dive into, all equally important. So, well, there we go. So yes, I'll wrap it up. Anything else? I didn't mean to cut you off, Cynthia.
No, I was just going to say thank you both so very much for making this possible. So you guys have been so gracious with your time and your talents, and we couldn't do this without you, and always love coming to the table with you guys. I learned so much, and I'm sure our survivors and caregivers that are on tonight learned a ton as well. So thank you so much.
Thank you, Dr. Geetha, again. Thank you, Cynthia. And it looks like Jamie, I don't know, Jamie, if other people can see that, but looks like we're back February 24th, and we're going to talk about quality of life and all of the topics that come with that. So
great.
That'll be another.
Thank you, Cynthia. Thank you, Dr. Clay.
Thank you.